Module 6. Central Nervous System and Head and Neck. Module 6. Central Nervous System and Head and Neck. Questions. 1. A 70-year-old woman presents with a sudden onset of right-sided hemiplegia and expressive dysphagia. She is otherwise well and has normal blood pressure on examination. Emergency CT shows a small subcortical acute hemorrhage in the inferior posterior left frontal lobe. Elsewhere, throughout the brain, there are smaller acute and subacute hemorrhages in the subcortex and a background of lacunar infarction. There is also marked brain atrophy in excess of that expected for the patient's age. Changes consistent with diffuse leukoencephalopathy are also seen. What is the most likely underlying pathological condition? A. Malignant hypertension. B. Acute disseminated encephalomyelitis. C. Neurosarcoidosis. D. Neuroamyloidosis. E. Hemorrhagic metastases. 2. A child. Module 6. Central (322). Module 6. Central Nervous System and Head and Neck. Answers. 1d. Cerebral amyloid angiopathy is characterized by deposition of B-amyloid protein in cortical, subcortical, and leptomeningeal vessels. It usually occurs in sporadic form and increases in frequency and severity with increasing age. The condition produces a wide variety of clinical symptoms and varied imaging appearances. Many cases are asymptomatic, but progressive neurological symptomatology and cognitive decline may be a feature. Chronic hemorrhage in a distinctive distribution, or catastrophic acute intracerebral/subarachnoid hemorrhage, may also occur. Amyloid angiopathy should be strongly considered in elderly normotensive patients with spontaneous intracranial hemorrhage, particularly when associated with leukoencephalopathy and atrophy related to small vessel cerebrovascular disease. Definitive diagnosis is usually only made postmortem, with a presumptive diagnosis made on clinical presentation and imaging findings. Chow et al., 2006. 2e. Holoprosencephaly is failure of the primitive brain to cleave into two hemispheres, and is commonly associated with midline facial abnormalities, ranging from cyclopia to hypertelorism, and absence of many intracranial midline structures. There are three types, the most severe being the allobar form, which shows no cleavage at all, with absence of the falx cerebri and third ventricle, fusion of the cerebral hemispheres and thalami, and a single large lateral ventricle. The semilobar form has variable cleavage with a partially formed falx, rudimentary third ventricle, and variable cleavage of the thalami, lateral ventricles and cerebral hemispheres. In the lobar type of holoprosencephaly, brain formation may be nearly normal, but the septum pellucidum is always absent, as in all forms. The falx, corpus callosum and ventricular system may be normal in the lobar type. Weissletter et al., 2007, 573-4. 3d. Toxoplasmosis is the most common cause of a cerebral mass lesion in patients with AIDS. Typical appearances are of multiple, hypoattenuating, 2 cm lesions with a predilection for the basal ganglia. Lymphoma is the second commonest mass lesion, with characteristic features including hyperdense lesions, though less frequently than in non-AIDS lymphoma, in a periventricular location with subependymal spread. Lesions in both conditions may show solid or ring enhancement. Hemorrhage is unusual in lymphoma, but may be seen in toxoplasmosis. Module 6, Central Nervous System and Head and Neck Answers. 323. Particularly following treatment. Thalia. Child who undergoes MR of the brain for clinically apparent facial abnormalities is shown to have a defect of midline cleavage of the brain. What structure is abnormal or absent in all forms of holoprosencephaly, and therefore is the most sensitive indicator of a midline cleavage abnormality? A. Falx cerebri B, third ventricle C, fourth ventricle D, corpus callosum E, septum pellucidum. 3. A 37-year-old man with AIDS presents with confusion, lethargy, and memory loss. CT of the brain demonstrates multiple supratentorial enhancing masses. Which imaging feature favors a diagnosis of toxoplasmosis rather than primary CNS lymphoma? A. Subependymal distribution B, lesions hyperdense on unenhanced CTC, lesion size 0.3 cm D, hypovascularity on Mr. Perfusion study E, increased uptake of thallium, 201 on SPECT. Module 6, Central Nervous System and Head and Neck Questions. 295. 4. An 80-year-old man presents acutely with a dense hemiplegia. CT perfusion is performed soon after admission, which suggests that the entire involved arterial territory is beyond recovery. Which of the following options represents the most likely combination of cerebral blood flow, mean transit time, and cerebral blood volume, respectively, seen within the affected brain parenchyma, compared with unaffected parenchyma? A. Increased, increased, increased B, increased, increased, decreased. C. Increased, decreased, decreased D, decreased, decreased, decreased E, decreased, increased, decreased. Lymphomas demonstrate increased perfusion relative to surrounding tissue, while toxoplasmosis is hypovascular. Differentiation is important, as early radiation therapy confers a significant survival advantage in CNS lymphoma. Grossman and Yusum, 2003, 153-6, Brandt and Helms, 2007, 133. 4e. Cerebral perfusion CT can distinguish viable but ischemic tissue, the penumbra, from tissue that is beyond recovery. Other uses include evaluation of vasospasm after subarachnoid hemorrhage, assessment of cerebrovascular reserve with acetazolamide, cerebral arterial vasodilator, in cases of vascular stenosis, evaluation of collateral flow and cerebrovascular reserve in patients having temporary balloon occlusion, and assessment of microvascular permeability of intracranial neoplasms. Cerebral perfusion CT utilizes the central volume principle. This states that CBF 1/4 CBV/MTT, where CBF is cerebral blood flow, CBV is cerebral blood volume, and MTT is mean transit time. In practice, 2 CT perfusion techniques can be used. One is perfused blood volume mapping, in which a quantity is assigned to cerebral blood volume by subtracting unenhanced CT data from CT angiographic data. It has the advantage of imaging the whole brain. The second technique is a dynamic, contrast-enhanced technique that acquires data from a limited number of axial slices and monitors the first pass of an iodinated contrast agent bolus through the cerebral circulation. This requires an unenhanced CT brain, followed by a dynamic CT performed during injection of 50 ml of iodinated contrast, 300 mg I/ml, at 4 ml/s. The first pass of contrast is observed in the brain. Cerebral perfusion is related to the concentration of iodinated contrast, which is directly related to the attenuation measured. Several maps are produced, including the CBV, CBF, and MTT. MTT is derived from arterial and venous enhancement curves, measured by using regions of interest placed on an artery, one that is not occluded as part of an acute event, and a venous sinus. CBV is the area under the enhancement curves, and CBF is obtained from the central volume equation. Differentiation of infarcted brain from penumbra is important because, while penumbra can be saved by timely thrombolysis, infarcted tissue has an increased risk of bleeding from thrombolysis with no chance of recovery. CBF is decreased in both ischemia and infarction. MTT is longer 0.6s in both, while CBV is decreased in infarct but increased, or normal, in the penumbra due to cerebral autoregulatory mechanisms. MTT is the most sensitive for stroke. So this or CBF can be used to detect stroke, while CBV is used to determine whether there is infarct or reversible ischemia. Hofner et al., 2004. Module 6, Central Nervous System and Head and Neck Answers. 324. 5d. Acute disseminated encephalomyelitis is an acute autoimmune demyelinating disease of the central nervous system that affects children more commonly than adults. It is usually triggered by an inflammatory response to viral infections or vaccinations. The main symptoms are decreased level of consciousness, varying from lethargy to coma, convulsions, and multifocal neurological symptoms. MR imaging findings are of multifocal, large, confluent or punctate, high-signal, white matter lesions on T2W/FLAIR images. Lesions are responsive to treatment with steroids and in 80% of cases completely resolve. A hemorrhagic, hypercute variant, acute hemorrhagic leukoencephalitis, has also been described and is known as Hess disease. In addition to the usual findings, there are multiple, white matter hemorrhages and rapid development of profound generalized mass effect. Hess disease is usually fatal within a few days. Honkanemi et al. 2001. 6d. Diffusion-weighted MRI provides image contrast, which is different from that provided by conventional MR technique. Decreased. 5. A 14-year-old boy with a recent history of viral upper respiratory tract infection presents with a 2-day history of rapid onset of fever and lethargy progressing to reduced consciousness and says yours. MRI shows several large lesions in the cerebral white matter, and a diagnosis of acute disseminated encephalomyelitis is made. Which additional finding is associated with the most fulminant course of this disease, with a median survival of only 6 days? A. Gray matter involvement. B. High signal in the CSF on FLAIR images. C. Generalized brain edema. D. Areas of petechial hemorrhage. E. Enhancement with intravenous techniques. The sequence enables attenuation measured. Several maps are produced, including the CBV, CBF, and MTT. MTT is derived from arterial and venous enhancement curves, measured by using regions of interest placed on an artery, one that is not occluded as part of an acute event, and a venous sinus. CBV is the area under the enhancement curves, and CBF is obtained from the central volume equation. Differentiation of infarcted brain from penumbra is important because, while penumbra can be saved by timely thrombolysis, infarcted tissue has an increased risk of bleeding from thrombolysis with no chance of recovery. CBF is decreased in both ischemia and infarction. MTT is longer 0.6s in both, while CBV is decreased in infarct but increased, or normal, in the penumbra due to cerebral autoregulatory mechanisms. MTT is the most sensitive for stroke. So this or CBF can be used to detect stroke, while CBV is used to determine whether there is infarct or reversible ischemia. Hofner et al. 2004. Module 6, Central Nervous System and Head. Five D. Acute disseminated encephalomyelitis is an acute autoimmune demyelinating disease of the central nervous system that affects children more commonly than adults. It is usually triggered by an inflammatory response to viral infections or vaccinations. The main symptoms are decreased level of consciousness, varying from lethargy to coma, convulsions, and multifocal neurological symptoms. MR imaging findings are of multifocal, large, confluent or punctate, high-signal, white matter lesions on T2W/FLAIR images. Lesions are responsive to treatment with steroids and in 80% of cases completely resolve. A hemorrhagic, hypercute variant, acute hemorrhagic leukoencephalitis, has also been described and is known as Hess disease. In addition to the usual findings, there are multiple, white matter hemorrhages and rapid development of profound generalized mass effect. Hess disease is usually fatal within a few days. Honkanemi et al. 2001. Intravenous gadolinium. 6. Which of the following conditions will typically demonstrate unrestricted diffusion on Mr. DWI and ADC map? A. Epidermoid cyst. B. Acute infarction. C. Cerebral abscess. D. Glioblastoma multiforme. E. Viral encephalitis. 2001. 6D. Diffusion-weighted MRI provides image contrast, which is different from that provided by conventional MR techniques. The sequence enables the measurement of net macroscopic water movement, which is anisotropic, varies in different directions, particularly in white matter. Restricted diffusion is seen as high signal on DWI, which is a T2W image with signal degraded by diffusion, and low signal on the ADC map. Restricted diffusion occurs in tissue that does not allow free movement of water molecules, such as areas of infection due to the high viscosity and cellularity of pus. Similarly, epidermoid cysts are very cellular and so also show restricted diffusion, a feature that helps distinguish them from arachnoid cysts, which are fluid structures. In stroke, restriction in water diffusion occurs within minutes after the onset of ischemia. The basis of this change is not completely clear, but is thought to be related to the cytotoxic edema seen in ischemic cells due to the impairment of the Na+/K and ATPase pumps, which are very energy dependent, leading to loss of ionic gradients, and a net translocation of water from the extracellular to the intracellular compartment, where water mobility is relatively more restricted. Schaefer et al. 2000. 7c. 7. A 77-year-old patient presents with amaurosis fugax. A carotid Doppler ultrasound scan is performed. Which of the following findings would be suggestive of an internal carotid artery stenosis of 0.70% using Consensus Conference of Society of Radiologists in Ultrasound 2002 criteria? A. Internal carotid artery peak systolic velocity of 120 cm/SB. Internal carotid artery end diastolic velocity of 80 cm/S. C. Ratio of peak systolic velocities in internal and common carotid arteries of 0.4.0 d. Loss of flow in common carotid artery during diastole. E. No spectral broadening. C. A peak systolic velocity of 0.230 cm/s, 250 cm/s in some texts, in the internal carotid artery, an end diastolic velocity of 0.100 cm/s, and a ratio of peak systolic velocities between the internal and common carotid arteries of 0.4.0 are all features that suggest a stenosis of 0.70%. Loss of flow, or even reversal of flow, in the common carotid artery suggests an occlusion or very high-grade stenosis. The grade of stenosis. Module 6, Central Nervous System and Head and Neck answers. 325. That is suitable for surgical rather than medical treatment has been shown to be 70%. Eight. A 62-year-old man with a history of falls and confusion undergoes MR of the brain. This demonstrates a subdural hematoma of high signal intensity on T1W images and of high signal intensity with a hypointense rim on T2W images. What is the most likely age of the hematoma? A. 6 hours. B. 872 hours. Center 3 days to 1 week. D. 1 week to several months. E. Several months to several years. %. Dehnert, 2007, 379. 8d. In the first 3-6 hours, hyperacute stage, following hemorrhage, the intact red cells contain mostly oxyhemoglobin, which appears hyperintense on T2W images. Desaturation occurs peripherally, forming deoxyhemoglobin, which is seen as hypointensity on T2W images. In the acute stage, 872 hours, there is rapid deoxygenation of the oxyhemoglobin to deoxyhemoglobin, which, together with the high protein content of the clot and susceptibility effects, results in ISO to hypointensity on T1W images and hypointensity on T2W images. In the early subacute stage, 3-7 days, oxidation of deoxyhemoglobin to methemoglobin occurs inside the red cell, resulting in characteristic hyperintensity on T1W images due to paramagnetic effects, and marked hypointensity on T2W images. In the late subacute stage, 1 week to months, extracellular methemoglobin results in persistent hyperintensity on T1W images, but increasing signal intensity on T2W images with peripheral susceptibility effects causing a low-intensity rim. In the chronic stage, months to years, iron atoms are deposited as hemosiderin and ferritin, which cause susceptibility effects resulting in low signal intensity on both T1W and T2W images. Grossman and Yusum, 2003, 20815. 9c. The hypodense artery sign is described. 9. A 75-year-old man undergoes an aortic valve replacement. His GCS remains low as the general anesthetic effect wears off, and a new left-sided weakness is observed. Unenhanced CT of the brain is performed. The CT reveals a hypodensity of attenuation value 30 Hu within the first segment of the right middle cerebral artery. Which of the following options is most likely to explain the patient's abnormal neurology? A. Right middle cerebral artery thromboembolic occlusion. B. Cerebral embolism as part of the fat embolism syndrome. C. Right middle cerebral artery fat embolism. D. Right middle cerebral artery air embolism. E. Right middle cerebral artery dissection. 10. A 46-year-old patient presents with described, representing a single, large, macroscopic fat embolus within the middle cerebral artery, giving rise to a stroke syndrome. It may occur during cardiac surgery, resulting in dislodgement of fat from the surrounding tissue. This is distinct from the shower of microscopic fat emboli that occurs in the fat embolism syndrome. Lee et al., 2005. 10e. The lymph node chains in the neck are complex and consist of a superficial circular nodal group. With an enlarged level for lymph node in the neck. Histology from FNA demonstrates metastatic SQUA mouse cell carcinoma. Which of the following is the most likely site of the primary malignancy? A. Oral cavity. B. Nasopharynx. C. Tongue. D. Salivary gland. E. Larynx. Group and a deep cervical chain. Supraglottic laryngeal squamous cell Cell carcinoma tends to spread to the high internal jugular vein chain of nodes, which are in level 2 with tumors of the epiglottis, aryepiglottic folds and pyriform sinuses most likely to present with adenopathy. This can be ipsilateral, most common, contralateral or bilateral. Subglottic tumors tend to spread to bilateral middle, or lower level nodes of the internal jugular vein chain in level 3 or 4. The level for lymph nodes also drain the hypopharynx, thyroid and upper esophagus. The oral cavity, including the tongue and nasopharynx, drains to the level 2 nodes. The salivary glands drain to level I or 2. Module 6, Central Nervous System and Head and Neck Answers. 326. Nodes. Tumors confined to the vocal folds do not normally metastasize to lymph nodes. Werner et al., 2003. Larynx. 11. Degenerative spinal vertebral body end plate changes, as seen on MRI, may have which of the following appearances? A. Type I high T1W and low T2W signal. B. Type I low T1W and low T2W signal. C. Type 2 high T1W and high T2W signal. D. Type 2 low T1W and high T2W signal. E. Type 2 high T1W and low T2W signal. 11. C. The end plates in degenerative disc disease have 3 described appearances during their evolution, which are also known as modic changes. Type I, marrow edema, changes show low signal on T1W and high signal on T2W sequences. Type 2, fatty marrow, changes show high signal on both T1W and T2W sequences. Type 3, sclerosis, changes are low signal on both T1W and T2W sequences. Terranzadeh et al., 2000. 12a. Loss of myelinated fibers and gliosis in the posterior and lateral columns of the spinal cord are the histopathological hallmarks of Friedreich's ataxia. On MRI, the predominant radiological finding is thinning of the cervical spinal cord and medulla, and there may be associated mild Mild cerebellar atrophy. Conversely, in the majority of other forms of ataxia, 297. 12. A14, year, old boy presents with a grossly abnormal gait, kyphoscoliosis and upper limb tremors. MRI shows mild atrophy of the cerebellum, and much more marked cervicomedullary junction thinning with decreased anteroposterior diameter of the upper cervical spinal cord, which returns normal signal. What is the most likely diagnosis? A. Friedreich's ataxia. B. Creutzfeldt-Jakob disease. C. Olivopontocerebellar atrophy. D. Huntington's disease. E. Tuberous sclerosis. Sclerosis. 13. What are the ataxia such as early onset cerebellar ataxia and olivopontocerebellar atrophy, atrophy of the cerebellum, and pons predominates with relative sparing of the cord. Although cerebellar atrophy may be seen in Friedreich's ataxia, it is less pronounced than in these other diseases. Mascalchi et al., 1994. 13a. Pituitary Typical appearances of a pituitary microadenoma on early, contrast-enhanced T1W MR images. A. Focus of hypointensity within normal enhancing gland. B. Focus of enhancement within normal, non-enhancing gland. C. Lesion and normal gland enhanced similarly. D. Hyperenhancing focus within normal, mildly enhancing gland. E. Not usually visualized on this sequence. Pituitary microadenomas are typically hypointense compared with the normal gland on unenhanced T1W images, and the diagnosis can usually be made without contrast. Following contrast, the microadenoma does not initially enhance, and maximal contrast between enhancing normal gland and pituitary tumor is seen on dynamic images obtained within the first minute. Contrast enhancement may therefore be useful in identifying lesions that are not obviously hypointense on the unenhanced images. However, contrast enhancement of the tumor relative to the normal gland may be seen on delayed 0.20 minutes images. Grossman and Yusum, 2003, 532-3. A 20-year-old man presents with gradual Gradual onset of neck pain, and a painful lump in the upper neck posteriorly. Plain films show an apparent destructive lesion of the C2 vertebra. MRI shows a large lesion arising from the posterior elements of C2, and comprising multiple cysts, with fluid levels, with preservation of the vertebral body. What is the most likely diagnosis? A. Aneurysmal bone cyst. B. Giant cell 3. 14a. Aneurysmal bone cysts are seen mainly in patients under 20 years of age, 75%, and affect the posterior elements when involving the spine. They may arise de novo or secondary to another lesion such as a giant cell tumor, GCT, or fibrous dysplasia. Both GCTs and telangiectatic osteosarcomas may cause cysts with fluid levels on MRI, but GCTs arise from vertebral bodies and usually occur in the sacrum. Telangiectatic osteosarcomas usually affect long bones. Chodom S.R. Module 6. Two more. C. Chodoma D. Fibrous dysplasia. E. Telangiectatic osteosarcoma. 15. A 32-year-old man of African ataxia. On MRI, the predominant radiological finding is thin. Grossman and Yusum, 2003. African descent presents to the neurologist with a several-month history of headache followed by rapid onset of bilateral facial weakness and blurring of vision. An MRI shows thickening of the basal leptomeninges, which enhance with intravenous gadolinium. Abnormal areas are identified in the pituitary gland and optic and facial nerves, which all return low signal on T1W images and high signal on FLAIR images. What is the most likely diagnosis? A. Multiple sclerosis. B. Tuberculous meningitis. C. Neuroamyloidosis. D. Neurosarcoidosis. E. Lymphoma. Laredo et al. 2001. 15. D. Neurosarcoidosis is seen in up to 8% of cases of sarcoidosis, and has a tendency to involve the base of the brain. Cranial nerve involvement occurs frequently, and nerve palsies are a common presenting feature. Bilateral facial nerve palsies, particularly in young adults, are most commonly due to neurosarcoidosis. The most common imaging manifestation is diffuse basomeningeal thickening, which typically shows enhancement with intravenous gadolinium. Also frequently seen are meningeal nodules and deep white matter lesions with high T2 signal. Multiple or solitary parenchymal masses may also occur, which can have a ring-like appearance, and may therefore mimic primary or metastatic neoplasia. Koyama et al. 2004. 16b. Ependymomas are the commonest tumor. Module 6, Central Nervous System and Head and Neck Questions. 298. 16, a 46-year-old female presents with back pain and increasing weakness of the lower limbs. And Mr. Scan shows a lesion in the cord at the level of T11. Which of the following features would suggest an ependymoma rather than demyelination? A. Multiple lesions. B. Expansion of the cord. C. High signal on T2W images. D. Enhancement with gadolinium. E. Peripheral low signal on all sequences. Tumor of the spinal cord in adults, accounting for 40–60% of cord tumors. They present with a long history of pain and sensory or motor disturbance. Less commonly, bladder and bowel dysfunction may occur. Expansion of the cord is more often seen with ependymomas than with demyelination. Both lesions may enhance and have high signal on T2W images, but multiplicity is more often seen with demyelination. Peripheral low signal, usually indicating hemosiderin, is not a feature of either of these lesions. Sutton, 2002, 1666-8, Dehnert, 2007, 213-14. 17b. Once the presence of a mass has been established, the radiologist must determine whether the mass is intraaxial, arising within the brain parenchyma, or extraaxial, arising outside the brain. 17. A mass is seen peripherally in the middle cranial fossa on MR of the brain. Which of the following imaging features favors an intraaxial rather than an extraaxial location? A. Buckling of the gray-white matter interface. B. Expansion of the cortex of the brain. C. Expansion of the subarachnoid space. D. Medial displacement of all blood vessels by the mass. E. The mass has a dural base. A. Brain substance, in order to formulate an appropriate differential diagnosis. An extraaxial mass characteristically causes buckling of the gray-white matter interface, expansion of the subarachnoid space at its borders, and medial displacement of the vessels in the subarachnoid space. A dural base is also a feature of an extraaxial mass. Intraaxial masses characteristically cause expansion of the cortex of the brain, but no expansion of the subarachnoid space, and P-all vessels may be seen peripheral to the mass. Grossman and Yusum, 2003, 97-8. 18. A 35-year-old woman presents with progressive deafness and tinnitus in the left ear. She undergoes MRI, which demonstrates a 2 cm mass at the left cerebellopontine angle. Which of the following theators would favor a diagnosis of meningioma rather than vestibular schwannoma? A. Acute angle with the petrous bone. B. Hyperintensity on T2W images. C. Expansion of the internal auditory canal. D. Presence of a dural tail. E. Internal cystic degeneration and hemorrhage. Indicating hemosiderin is not a feature of either of these lesions. Sutton, 2002, 1666-8, Dehnert, 2007, 213-14. 17. B. Once the presence of a mass has been established, the radiologist must determine whether the mass is intraaxial, arising within the brain parenchyma, or extraaxial, arising outside the brain substance, in order to formulate an appropriate differential diagnosis. An extraaxial mass characteristically causes buckling of the gray-white matter interface, expansion of the subarachnoid space at its borders, and medial displacement of the vessels in the subarachnoid space. A dural base is also a feature of an extraaxial mass. Intraaxial masses characteristically cause expansion of the cortex of the brain, but no expansion of the subarachnoid space, and P-all vessels may be seen peripheral to the mass. Grossman and Yusum, 2003, 97-8. Module 6, Central Nervous System and Head and Neck Answers. 328. 18. D. The most common causes of a cerebellopontine angle mass are vestibular schwannoma, also called acoustic neuroma, 75%, meningioma, 10%, and epidermoid cyst, 5%. Features suggestive of a meningioma include a dural tail, thickening of enhancing adjacent dura resembling a tail extending from the mass, adjacent hyperostosis, and an obtuse angle with the petrous bone. Vestibular schwannomas make an acute angle. Distinguishing features of schwannomas include extension into the internal auditory canal, causing expansion of the canal, and flaring of the porus acousticus, bony opening of the internal auditory canal. Meningiomas may show a small tongue of extension into the canal but usually no expansion. Schwannomas undergo cystic degeneration and hemorrhage more commonly than meningiomas, particularly larger lesions, and may show very high signal on T2W images, which is unusual for a meningioma. Grossman and Yusum, 2003, 1058. 19. A 64-year-old woman presents. Presence with progressive headache and confusion. On CT, she is found to have multiple, well-defined, rounded, low attenuation masses of varying sizes in both hemispheres at the gray-white matter junction. The masses demonstrate intense enhancement following intravenous contrast, and there is considerable surrounding edema. Which of the following is the most appropriate next imaging investigation? A. Mammography. B. Thyroid ultrasound scan. C. Barium enema. D. Renal ultrasound scan. E. Chest radiograph. Module 6. 19. E. Brain metastases are the most common intracranial tumors. 6 primary tumors account for 95% of all brain metastases. Primary bronchial carcinoma is the most common, 47% of cases, though squamous cell carcinoma rarely metastasizes to the brain. Other common primary tumors are breast carcinoma, 17%, gastrointestinal malignancy, 15%, renal cell carcinoma, melanoma, and choriocarcinoma. Metastases characteristically occur at the gray-white matter junction, are multiple in 66% of cases, and typically appear as hypodense masses that demonstrate solid or ring enhancement. Dehnert, 2007, 309. Large schwannoma. A. Acute angle with the petrous bone. B. A 78-year-old male patient presents with signs of acute lumbar myelopathy. Lumbar spine radiographs show collapse of the L3 vertebral body, which is encroaching upon the spinal canal. Additionally, throughout the remaining visualized vertebral bodies, there is diminished density of the central trabecular bone with relative preservation of the cortex and thickening of the marginal trabeculations, which appear coarse. What is the most likely underlying condition of bone? A. Paget's disease. B. Pycnodyscystosis. C. Osteopetrosis. D. Gaucher's disease. E. Hyperparathyroidism. 309. 20a. The described appearance is of picture frame vertebral bodies and is seen in Paget's disease. The central osteoporosis can lead to insufficiency fractures and complications thereof. Rubber jersey spine has a similar appearance due to sclerosis of the end plates, but the anterior and posterior cortices are spared, and is seen with both hyperparathyroidism, usually secondary and associated with renal failure, and osteopetrosis. Pycnodyscystosis is a congenital disorder with sclerosis of long bones, causing obliteration of the medullary canal. Gaucher's disease causes osteosclerosis secondary to bone infarcts, often causing H-shaped vertebra due to central end plate collapse. Resnick and Kronsdorff, 2005, 578-81. 21a. Alzheimer's disease typically presents with atrophy. 21, a 52-year-old female presents with increasing short-term memory problems. CT and MR scans are normal. A perfusion scintigraphy study of the brain shows reduced perfusion in the posterior parietal regions bilaterally. What is the most likely diagnosis? A. Alzheimer's disease. B. Vascular dementia. C. Lewy body dementia. D. Frontotemporal dementia. E. Parkinson's disease. 22. What is the most sensitive sign? Atrophy and reduced perfusion to the mesiotemporal regions bilaterally, but in younger patients, it often presents with posterior parietal perfusion abnormalities. Vascular dementia shows patchy cortical and subcortical. Module 6, Central Nervous System and Head and Neck Answers. 329. Perfusion defects with involvement of the cerebellum. Lewy body dementia is similar to Alzheimer's disease, but with less occipital sparing. Parkinson's dementia is also similar, but with less mesiotemporal change and more involvement of the visual cortex. Sign on non-contrast CT for detecting early hydrocephalus. A. Cortical sulcal effacement. B. Uncal herniation. C. Enlarged third ventricle. D. Enlarged fourth ventricle. E. Enlarged temporal horns of the lateral ventricles. 23. A 22-year-old man presents with a 6-week history of progressive worsening confusion. Initial CT examination is normal. Parkinson's dementia is also similar, but with less mesiotemporal change and more involvement of the visual cortex. Al and Gumbier, 2004, 1437. 22e. In many cases of hydrocephalus due to subarachnoid hemorrhage, the temporal horns of the lateral ventricles become dilated sooner than the frontal horns. Dilatation of the temporal horn is often particularly conspicuous, as it is frequently not visualized at all on CT of normal brains. Uncal herniation is herniation of the medial temporal lobe into a subtentorial location, where it may exert pressure on the brain stem, and is a late sign of raised intracranial pressure, often presenting with oculomotor nerve palsy resulting in a fixed dilated pupil. Normal. Following neurological review, the patient undergoes MRI, at which the only abnormality seen is seen as high signal in the posterior portions of the thalami bilaterally on T2W and FLAIR images. What is the most likely condition? A. Acute disseminated encephalomyelitis. B. Variant Creutzfeldt-Jakob disease. C. Multiple sclerosis. D. Metachromatic leukodystrophy. E. Rasmussen's encephalitis. Module 6. Central nervous system and head and neck questions. 300. Hosoya et al., 1992. 23b. Variant Creutzfeldt-Jakob disease is a rare but important, transmissible, rapidly progressive spongiform encephalopathy, and a cause of dementia and death in young patients. The transmissible agent is thought to be a prion protein, proteins devoid of nucleic acid, and the condition is causally linked to bovine spongiform encephalopathy. CT is typically normal, but symmetrical hyperintensity in the pulvinar nuclei of the posterior thalami, pulvinar sign, on T2W or FLAIR Mr. images has been described as a specific sign for the variant form. The classic form affects an older age group and is often genetically linked, whereas the variant form is sporadic. The Pulviner sign is seen only in the variant form, with the classic type typically showing similar hyperintense abnormalities located in the caudate nucleus and putamen. Colley et al. 300. 24. A 60-year-old female admitted with severe, sudden-onset headache is found to have widely distributed subarachnoid hemorrhage. A saccular aneurysm is identified on CT angiography. From which of the following locations in the circle of Willis is this aneurysm most likely to arise? A. Basilar tip. B. Middle cerebral artery bifurcation. C. Junction of anterior cerebral and anterior communicating arteries. D. Pericallosal artery. E. Vertebral artery. 25. 2003. 24. C. It is at this location that 35% of Berry aneurysms are found. This is the same proportion that occurs at the junction of the internal carotid and posterior communicating arteries. 5% occur at the basilar tip and 20% at the middle cerebral artery bifurcation. 2% of the population have cerebral aneurysms. They are multiple in 20% of cases and giant in 25%, over 25 millimeters in diameter. They are caused by degenerative vascular changes, trauma, infection, tumor, and vasculopathy. The incidence is increased in adult polycystic renal disease, aortic coarctation, fibromuscular dysplasia, and Marfan's and Ehlers-Danlos syndromes. (25) A 70-year-old man is referred for CT scan of the brain due to sudden onset of left-sided hemiparesis and clinical diagnosis of stroke. Unenhanced CT shows a rounded area of low attenuation in the right posterior frontal lobe with local gyriform swelling and sulcal effacement. Upon questioning, he reveals a history of lung resection for malignancy 18 months previously. Which of the following imaging investigations would you perform next? A. No further imaging. B. CT of the thorax. C. CT of the thorax and abdomen. D. MRI of the brain. E. Contrast-enhanced CT of the brain. Weissletter et al. 2007, 513. Module 6, Central Nervous System and Head and Neck answers. 330. 25. E. In this scenario, the low attenuation and surrounding changes most likely represent brain edema. This may be due to an evolving infarction or edema around a metastatic deposit from the previous lung cancer. Differentiation between the two will immediately affect patient treatment, as antiplatelet therapy for ischemic stroke will increase the risk of hemorrhage from a metastasis and therefore should be withheld if a metastatic deposit is suspected or diagnosed. The primary factor in determining whether a lesion will enhance on CT after administration of intravenous iodinated contrast is the integrity of the blood-brain barrier in that region of the brain substance. A large molecule such as iodinated contrast would not be able to enter the brain unless the integrity of the barrier were compromised. The majority of aggressive tumors, including metastases, will disrupt this barrier and so contrast. Enhancement will be seen in the solid component of these lesions. Acute infarction will typically not show areas of enhancement. Grossman and Yusum, 2003, 5-7, Cha, 2000. 26. A 43-year-old 43-year-old man presents with cough and numerous masses in the neck bilaterally. CT confirms multiple lymph nodes that enhance peripherally and contain areas of calcification. A cavitating lesion is noted in the right lung apex. What is the most likely diagnosis? A. Tuberculosis. B. Metastatic laryngeal carcinoma. 2006. 26. A. Tuberculous lymphadenitis is the most common form of head and neck tuberculosis, representing 15% of all extrapulmonary tuberculous infections. It is frequently bilateral, and the more inferior the involved nodes, the higher the prevalence of associated pulmonary disease. Peripherally enhancing lymph nodes are seen with tuberculosis, metastatic disease, usually squamous cell tumors, lymphoma, or infection. The presence of calcification suggests tuberculosis, but it may also be seen with papillary or medullary thyroid carcinoma. The other diagnoses listed may cause cervical lymphadenopathy, but the lung lesion would be unusual in all except a cavitating squamous cell carcinoma of the lung. Moon et al., 1997. Carcinoma C, metastatic nasopharyngeal carcinoma D, metastatic papillary thyroid carcinoma E, metastatic squamous cell carcinoma of the lung. 27, a 22-year-old man with von Hippel-Lindau syndrome presents with headaches, vomiting, and ataxia. CT of the brain demonstrates an abnormality in the posterior fossa. What are the most likely findings? A. Cystic lesion with an enhancing neural nodule B, multiple ring-enhancing lesions with surrounding edema C, gyriform cortical calcifications D, multiple calcified subependymal nodules E, hypodense. 27. A. Hemangioblastomas are the most commonly recognized manifestation of von Hippel-Lindau syndrome. They usually occur in the cerebellum, and may be multiple in up to 15% of cases. Patients also commonly develop renal cell carcinoma, and difficulty may occasionally arise in distinguishing metastases from multiple hemangioblastomas. Typical features are of a cystic mass in the hemisphere or vermis, with an enhancing neural nodule, though entirely solid lesions may also occur. Calcification is not a feature. Gyriform cortical calcifications are a feature of Sturge-Weber syndrome, and usually occur in the temporoparieto-occipital region. Calcified subependymal nodules, comartomas, are a feature of tuberous sclerosis. A hypodense, ill-defined mass with. Module 6, Central Nervous System and Head and Neck, answers. 331. Central necrosis and marks surrounding edema is a classic appearance of a glioblastoma multiforme. Chapman and Nachialny, 2003, 451, Grossman and Yusum, 2003, 131-2. Hypodense, ill-defined mass with central necrosis and marks surrounding edema. Module 6, Central Nervous System and Head and Neck, questions. 301. 28. With aging, iron accumulates in tissues of the brain and is seen as low signal on both T1W and T2W sequences at MRI. Which of the following locations for iron deposition is pathological in a 60-year-old man and may indicate onset of dementia? A. Putamen B, globus pallidus. C. Red nucleus D, dentate nucleus. E. Pars reticulata. 29 and 85. 2. 28a. Non-heme brain iron is normally found within oligodendroglia and astrocytes, with smaller amounts in neurons and myelinated axons. Half is found within the mitochondria, and 10% in the nuclei, and 40% represents a soluble fraction. The areas of maximum iron concentration in normal adults are found in the globus pallidus, red nucleus, pars reticulata of the substantia nigra, and dentate nucleus of the cerebellum. The brain concentration is independent of general body stores, and the mechanism by which it crosses the blood-brain barrier is not fully understood. By the 8th decade, the concentration of iron may increase in the caudate nucleus and putamen to levels similar to those seen in the globus pallidus. Excessive or premature accumulation in these areas has been seen in various forms of senile dementia, including Alzheimer's disease. Iron deposition is identified on T1W and T2W sequences as signal hypointensity due to magnetic susceptibility. Dreyer, 1988. '85-year-old female presents with low back pain and is tender over the sacrum. Radiographs show a generalized reduction in bone density. MRI demonstrates symmetrical, bilateral, linear areas of signal abnormality in the sacral ali, which are low signal on T1W and high signal on STIR images. There is no history of trauma, but the patient does have a history of other AP for cervical carcinoma many years previously. What is the most likely diagnosis? A. Insufficiency fracture. B. Metastases. C. Ankylosing spondylitis. D. Reiter's syndrome. E. Post-radiotherapy change. A 1988B. 29A. Insufficiency fractures tend to occur in elderly female patients and manifest with pain. They are notoriously difficult to diagnose on plain film due to overlying soft tissues and bowel gas. MR and bone scans demonstrate them well, often in an H configuration, Honda sign. Metastases tend to cause multiple focal areas of change. Ankylosing spondylitis and Reiter's syndrome are known causes of sacroiliitis, which would cause changes on MRI more localized to the iliac sides of the sacroiliac joints. Post-radiotherapy changes tend to be those of fatty marrow replacement, with high signal on both T1W and T2W, and low signal on STIR images. Dial ETL 2001. 30D. Carotid cavern. Cavernous sinus fistula can be caused by penetrating injury, base of skull fracture, or rupture of an intracavernous internal carotid artery aneurysm. Drainage from the affected cavernous sinus. Change. 30. A patient presents with diplopia, and is found to have unilateral restricted eye movements. On MRI, the extraocular muscles of the same eye are seen to be enlarged and edema too. Which of the following additional features favors a carotid cavernous sinus fistula as the diagnosis, over Graves' disease, lymphoma, or orbital pseudotumor? A. Distal tapering of the swollen extraocular muscles. B. Stranding in the orbital fat. C. Extraocular muscles isointense to fat on T2W images. D. Dilated superior ophthalmic vein. E. Extraocular muscle swelling involving the tendons. Sinus is via the superior ophthalmic vein, contralateral cavernous sinus, petrosal sinus, and, rarely, cortical veins. Pulsatile exophthalmos and orbital brute are evident, as are chemosis, conjunctival edema, and increased intraocular pressure. On imaging, the cavernous sinus may be enlarged, and can cause erosion of the sella, and enlargement of the superior orbital fissure. Regarding the differentials for extraocular muscle swelling, Graves' disease typically spares the muscle attachments, whereas Module 6, Central Nervous System and Head and Neck, answers 332. Inflammatory orbital pseudotumor affects the tendons while also causing orbital fat stranding. Dehnert, 2007, 344.